He's come to us all the way from Kelowna today, and he just started a movement disorder clinic in Kelowna in August, and we are so grateful for both the Interior Health Authorities and the UBC Okanagan campus's support of recruiting Dr. Wile to Kelowna. He's been trained out at the Movement Disorder Clinic as a specialist, a neurologist with a specialization in movement disorders. And things just fell into place. The Okanagan obviously has a high prevalence of Parkinson's disease, as age 65 plus is still when most of people with Parkinson's do get diagnosed. Although we are seeing more and more, unfortunately, in a younger age as well. But obviously, the Okanagan has welcomed Dr. Wile with open arms, and we're just thrilled to see more resources being spread out across the province. So he has quite a list of a long list of accomplishments, and when he does come up, you'll see he is pretty young to have done all these incredible things. So first he did his Bachelor of Science in Psychology, and he followed that up with a Master of Science in Behavioral Neuroscience at McGill. He then completed his Doctor of Medicine in Neurology at the University of Calgary and received his certification in neurology from the Royal College of Physicians and Surgeons of Canada. And then, as I said, he went to UBC and completed a clinical movement disorders fellowship that was supported by the peer review program through Parkinson's Canada. And he was under Dr. John Stossel's supervision. Probably a number of you have Dr. Stossel as your specialist. He focused on genetic and brain imaging markers of clinical differences in Parkinson's disease. And then he got enticed to move to Kelowna and begin the movement disorder clinic there. So please join me in welcoming Dr. Wile.
Thanks very much. I'm just delighted to be here, and it's lovely to meet some of you. Hopefully I'll get a chance to talk to you individually more after and answer questions, but I'd like to just give an overview of Parkinson's today. This is a new diagnosis seminar, so I want to tell you a bit about the disease and talk about the complexity. From the standpoint of neurology, Parkinson's disease is one of the most complex disorders that we treat and deal with. And from the patient's perspective as well, it's extremely complex, and it's more than just motor symptoms, which is something that's been an emphasis in the field for the last 10 to 15 years. And so I want to give you an overview of the different problems that patients often face, some of which you may recognize and others of which you may not, but just to give you an idea of that. And then an overview of the treatment, because the treatment is also very complex, and it can be very confusing in terms of how the different medications work and how they interrelate and what symptoms they should be treating. So I'll start just by talking about basically what Parkinson's disease is. And I like to use this rusty bucket analogy for a few reasons. So rust you can think of as a very slow and gradually progressive process that affects metal over time. So metal is still doing its job, it still can contain things, but at some point the rust creates a hole in the bucket, and things start to leak out. And we think that something very similar is occurring with some of these neurodegenerative disorders like Parkinson's disease. So we know that from autopsy studies, for instance, that when patients are diagnosed with Parkinson's disease based on their motor symptoms, they've already lost a substantial portion of the dopamine-containing neurons in the midbrain. And so we think that the process has been going on for many years when people finally do get symptoms. That's one of the main challenges for treatments with Parkinson's that we think might slow or stop progression, is we are diagnosing people when the disease is already quite established. So one of the challenges in the field for us is to try and identify people earlier and earlier. So we think that this is because of a combination of genetic and environmental factors for most patients, and I'll get into that in a little more detail. But first, I just want to show you this basic schematic. to give you an idea of the anatomy of Parkinson's disease. So you don't need to know the anatomy, but the concept is there's all these little wires that you see going from the bottom part of the figure up toward the top part of the figure. The little blue hieroglyphics up there are basically the movement computer in the brain. So it's called the basal ganglia, and this is an area of brain structures that work together to coordinate and initiate movements. And that is a process that's driven by this brain chemical called dopamine. So dopamine is made in these neurons that live in this area at the bottom of the screen called the substantia nigra. And you can think of it like a bunch of tiny little wires or tubes that go from there up to the basal ganglia, and they release dopamine on demand when it's needed. It's a very exquisite system, but when you lose those neurons, which is illustrated on the right side of the screen, then you have fewer of these little tubes going up to the movement computer. And so that creates changes in how people respond to the medications and things, because those neurons can't support movement appropriately. So if we look at this in autopsy slices of that lower part of the screen you saw before, the midbrain, in a healthy patient, you'll see in the top that little dark stripe that's in the lower part of the pathology slice. And that is where the dopamine neurons are. So they contain a substance that makes them dark, and that's why this area of the brain is called the substantia nigra. So in Parkinson's disease, you'll see in the lower part, the dark stuff is not there. And so that's kind of the pathologic evidence to the naked eye that the patient probably has Parkinson's. At a microscopic level, there are other changes that confirm that. So this is a side view of the brain now, so going down the middle, and you'll see that the midbrain is shown kind of at the very top of that little stem there. That's the trunk of the tree, or the brain stem, and the midbrain is where those dopamine neurons are that I've shown you on the last slide. And we now think that very likely what's happening is that there's a process underway that affects structures below the midbrain. And when it eventually spreads to the midbrain, people get motor symptoms. They get movement symptoms. But we think there's much more going on than just dopamine changes in the brain. And some of those things may occur earlier. And that may be why some patients have other symptoms well before they have movement symptoms that in retrospect maybe were part of the disease. So that can include changes in sleep. It can include changes in mood and changes in sense of smell and other things like that. So if we look at this in another way, so if you think of all the patients with Parkinson's disease like a tree, and you think of the cause of Parkinson's as these roots, you can see that there's a variety of different causes. So if we divide them into 7 big groups of people, so probably 1 in those 7 will have some family history. So about 14% of people have a family history of Parkinson's disease in a first-degree relative or a grandparent or something like this. And then among those people, a number of them we think probably have a gene mutation that is in some way responsible for Parkinson's. So there are dozens of gene mutations which have been shown to contribute to Parkinson's. And we think that probably people have sort of an overall genetic makeup that might put some people at slightly higher and some people at slightly lower risk of developing this condition. And then that risk is kind of modified by the different things that happen to you in your life, such that some people, the system in the brain for disposing of these abnormal proteins is kind of overwhelmed, and then it sets in motion a process that eventually becomes Parkinson's disease. So these are some alphabet soup examples of these different genes that have been shown in the lab and in larger human studies to cause Parkinson's. The ones on the top sort of cause, they're dominant, autosomal dominant mutations. The ones on the bottom are what are called recessive mutations. But just the idea is that there's a wide variety of different genetic factors. So we know, I don't intend for you to read that, but this just shows that there's a lot known about what happens in a cell that goes wrong with Parkinson's based on studies of people with these gene changes. So a lot of these proteins and genes encode things that have to do with this kind of waste disposal system that the neuron has. And we think, as I said before, for some patients, there's a process set in motion that overwhelms the waste disposal system. So some of these things have to do with the waste disposal system itself. Some of them have to do with the way things move around within neurons. And it's extremely complex in terms of the causes of Parkinson's. So there's much that's been learned in the last 10 years and 20 years and so on, but much more to be learned as well. So to summarize, it's complicated, but if you want to take a step back and think about the big picture, we think that people have this varying amount of genetic risk, and then they have in some cases, some environmental stressors. For instance, some people might have a heavy level of exposure to pesticides or other toxins, and there are also some modifiable risk factors and protective factors. So, for instance, smoking and things like that, and coffee use and exercise may modify the risk of developing Parkinson's. So that combination of all these complicated things will eventually cause these brain cells that contain dopamine from those slides a few slides ago to stop working well. And then if that persists and if it gets worse over time, those cells start to die off. And then your brain early on will compensate for that as they're dying off, but at some point there's sort of a tipping effect where the compensation is overwhelmed, and that's when people get symptoms, and that's when they present to their doctor, and then the diagnosis is made. So there's a lot going on well before motor symptoms emerge. So just talking a little bit more about some of those risk factors for Parkinson's. So we know from large studies of populations and sort of what we call epidemiology, or how the disease spreads throughout geographical areas and among different groups of people, that people who are exposed to pesticides have a slightly higher risk of Parkinson's. This is usually industrial or heavy-duty stuff like rotenone or paraquat are the ones that are mostly known. But for instance, in agricultural areas, there's a slightly higher risk of developing Parkinson's on the whole. We know that head injury can be related. This is true for a lot of other degenerative conditions as well, but for Parkinson's, that's been shown in large groups of people. And as I said, rural living and well water drinking. Lower risk, so this is not an endorsement of smoking by any means, but we know that from population studies, tobacco exposure over time it predicts a slightly lower risk of developing Parkinson's. In fact, that may have to do with nicotine itself rather than actually smoking, but there are also some foods that contain nicotine in small amounts, and people are wondering, are those foods also protective in some way? Things like peppers and whatnot, and eggplant. Coffee drinking has been shown to have a slightly protective effect. We know from large studies that people who take anti-inflammatories seem to have a slightly lower risk of developing Parkinson's disease. That led to a bunch of studies of things like ibuprofen and things like that for Parkinson's disease, and they haven't shown much effect. But on a big level with millions of people, it seems to have some predictive effect. And then alcohol consumption and exercise. So this is an example of the kind of distribution of Parkinson's, or what we call the prevalence. And you can see that there's the red is bad, so there's more Parkinson's disease in areas where there's a lot of metal work and industrial processing and things like that. And so there's a lot of interest in this from an environmental standpoint and from a toxin exposure kind of standpoint to identify what those things are that do cause the risk because they're potentially modifiable. The other thing in terms of kind of distribution of Parkinson's to know is that as Jean mentioned, it's more common with age, so probably the most important risk factor is aging, and unfortunately that's not modifiable as of right now. But you can see this is a graph of how the prevalence of Parkinson's changes over the lifespan. So We think that most people get Parkinson's over age 65, and you can see that the prevalence goes up much higher when you get up to 85. So probably if we all lived 150 years, this would be way up high, but it's hard to say. Interestingly, women are in red here, and men are in blue, and you can see the prevalence is slightly higher in men. And that may have something to do with estrogen and hormonal differences between men and women, because we think estrogen may have a protective effect as well in terms of who develops Parkinson's. So that's kind of the overview of cause, and it's a little bit murky because that's the state that the field is in. We know a lot about finer details, but there's still not a unified, perfect understanding of what the cause of Parkinson's is. And in fact, it probably is more than one thing, and it's many different diseases. And that's probably something you'll know from knowing other people with Parkinson's. This disease can present in so many different ways, and it can affect people in so many different ways. And sometimes it's very, very gradual and slow, and sometimes it's very fast in the way it progresses. So I do want to touch on the symptoms a little bit to tell you a little bit more about that. Most of you will be familiar with these already, but in medical school, everybody learns this acronym TRAP to recognize Parkinsonism. So Parkinsonism is a term that describes this combination of signs and symptoms. So TRAP stands for tremor, rigidity, akinesia, also called bradykinesia, which is slowness of movement, and fatiguing of movements. So we don't just see movements that are slow all the time, but we see movements that are initially fast, and then they fatigue and get smaller and slower as people repeat movements. So that forms one of the main things we look for when we examine patients. Rigidity is stiffness, so we examine that in patients by moving the joints passively back and forth. And then the P is for postural instability. To sort of summarize what that means, it's basically falls. So when people are perturbed, if they're pushed or if they're bumped when they're standing, they're at more risk of falling because they lose the postural reflexes that normally keep you upright. There's some other kind of motor symptoms. So the motor symptoms can affect the voice. So often people will get softness of the voice. It can affect the facial expression. So there's something that is referred to as a masked face or a less expressive face, sometimes less animated would be a good way to describe it. Handwriting is a commonly recognized feature as well. So handwriting can get very small and difficult to read. And it has that similar pattern where initially print can be of normal size, but then gradually get smaller and smaller. It's sort of a fatiguing of the writing. And then hand function. This is something I always ask people about in clinics. So I ask people about cutting food, because that's a two-hand task. Brushing teeth, although these days most people have an electric toothbrush, so that's not a good question anymore. Tying shoes, things that require both hands, or doing fine movements like doing up buttons and getting clothing on. So hand function is an important one. But not just the things that are out at the extremity, the things in the middle part of the body are also affected by Parkinson's, and that shows up as things like trouble turning in bed. So patients will often say that they just feel stiff and they have a hard time flipping in bed, and that can disrupt sleep and fragment sleep. And poor sleep is a symptom of Parkinson's, and it also is sort of a vicious circle thing, because if you don't get good sleep, your symptoms will be worse the next day. So turning in bed. And then another thing that's kind of middle of the body symptom is difficulty standing from a chair, for instance. And people will often notice this when they're in a low-lying chair, like the seat of a car that's low to the ground, or like a camping chair, something like that. So that's kind of an overview of the motor symptoms. The illustration here is to show that for some people, there's different emphasis on these different motor symptoms. So a big capital T indicates that, some people have mostly tremor. And we sort of look at the pattern of motor symptoms when we examine patients over time. And in general, there's two broad groups of people with Parkinson's in terms of motor symptoms. There's people who mainly have tremor, and there's people who mainly have stiffness and slowness. And those two groups seem to have slightly different courses and sort of disease behavior over time. So for other people, they may have mainly stiffness and slowness, but no tremor. And this is one of the confusing things, because people will say, well, how can I have Parkinson's? I don't have any tremor. I've never had tremor. But in fact, that does occur fairly frequently. So probably 20 to 40% of people don't have tremor to a noticeable degree, but that do have Parkinson's. So it's a very, very different disorder from person to person. So what we do when we're asked to assess a patient for Parkinson's disease is we look for that combination of signs and symptoms, which is Parkinsonism. And basically that starts usually with a concern the patient brings. They say, I'm having trouble walking, or I've noticed a tremor, or I'm stiff. And then we go through all of these different motor symptoms as well as some non-motor symptoms, which I'll come to. And then people go through a detailed neurological exam to look for the characteristic signs and to look for what we would call red flags, or things that don't fit well with Parkinson's. Sometimes that's accompanied by extra testing if we think that's needed. And then really one of the best diagnostic tests is to follow a patient over time to assess how the disease progresses, because that's one of the key features of Parkinson's, is how it behaves over time. And we also look at how patients respond to treatments like levodopa or other dopamine containing medications. And that can be part of our diagnostic workup as well, to see how the treatments are working. So that's kind of the clinical aspect of it. If people do have certain red flags when we examine them, or on their history, or on brain imaging, for instance, they may not have typical Parkinson's. So people can have that set of signs and symptoms that I've called Parkinsonism without having Parkinson's disease. So if we look at big studies of people who present with that combination of things, tremor, stiffness, slowness, and loss of postural reflexes, probably about 80% of people, if we just look at the numbers, have typical Parkinson's disease, if you follow them for a long period of time and get the best diagnostic information you can. But there are other things that can look a lot like Parkinson's, but don't behave the same way and don't respond to treatment in the same way. So we try and weed those out when we're examining patients and taking the history, because the treatments are different. So if about 80% of people have typical Parkinson's disease, probably maybe 5 to 10% have either drug-induced Parkinson's, or they have some accumulation of stroke damage in the brain that can cause a similar picture. And then there's these other degenerative conditions that can look a lot like Parkinson's, like something called PSP, or progressive supranuclear palsy, which it tends to cause more problems with falls and balance, and also with eye movements. There's something called multiple system atrophy that tends to affect something called the autonomic nervous system and causes a lot of significant bladder dysfunction, lightheadedness, and that occurs very early in the disease, well before the motor symptoms. And then there's another condition called CBD, or corticobasal degeneration. So these things can all be sort of mimics of Parkinson's disease, and so we look out for those. Some patients do get brain imaging. It's not always needed, but just to give you an idea of what the brain imaging studies are like, on the far left of the screen you see a CT scan. So this is an X-ray based brain imaging test. And the CT basically looks at the density of the tissue, so it passes an X-ray through, and we see things as darker if the X-rays get through easily, and they're brighter if the X-rays can't get through. So you can see the bone around the edge is bright because X-rays don't pass through bone as well. And so we can use that to look at the contrast of these different tissues and look for things that can be cause of Parkinson's. Usually a CT scan and an MRI scan are normal in Parkinson's disease. The middle picture is an example of an MRI scan, and you can see those parts in the middle of the screen that are part of the basal ganglia. So this is called the caudate, and that's called the putamen. And you'll remember back from the very start of the talk, we talked about the dopamine-containing neurons sending their little signals up to this area of the brain. This is kind of the movement computer. So an MRI scan looks at that. It also looks at the midbrain where those dopamine neurons live, and usually it looks anatomically normal. There's research-based MRIs that are very, very strong and very high resolution or high detail that may have some clues to Parkinson's disease, but it's not something that is of clinical use at the moment. On the far right of the screen, you see a typical appearance of a PET scan. So PET is a technique where people get a chemical injected into the vein, and that chemical binds on to a certain protein or something in the brain, and then we can look at where that's distributed. So, for instance, we can bind it to dopamine receptors in the brain, or other elements of the dopamine synapse, or things that occur that live there in the basal ganglia, or that movement computer. And then we can see, has there been a change in the level of dopamine chemical that's in that part of the brain? So that can be a useful tool, but it doesn't distinguish Parkinson's disease from other conditions that can look like Parkinson's. So, for instance, we can see the similar appearance in PSP or other conditions like that. So it's not generally a useful diagnostic test either, and it's mainly used for research. So I've told you about motor symptoms. It's important to know that there's a very high prevalence of these other non-motor features in Parkinson's disease. So the numbers on the left are small and hard to read, but just to give you an idea, in Parkinson's, probably 50 to 60% of patients have anxiety, and the same proportion roughly have fatigue. Those are extremely common. A lot of patients complain of insomnia, of bladder dysfunction, urinary urgency or a sudden need to pee without much warning. Drooling is a common one. The other ones that are there, smell changes, changes in memory, constipation is very common, depression is very common. So there are a number of different things, and I'll go over them in a little more detail. But fatigue and anxiety are very common. The other question which people often ask, and I've touched on this already, is, what does this mean for me? So how long am I going to have Parkinson's? How long is the disease course? And what symptoms am I likely to experience? And the answer is usually we don't know, because it takes time to understand how an individual patient's disease is going to progress and change over time. And like I said, so some patients may have very minimal symptoms for years and years. We usually say for at least 5 years with treatment, people can often have very little disability, sometimes much longer, so even 10 years without much effect or impact on life. But other patients have symptoms that don't get completely treated, and they start having problems with their function early on. So problems with home life, with work life, with recreation or social life. And when those things come up, that's what we try and treat and target. This is kind of a cartoon of what, in general, can happen over time. So you'll see on the far right of the screen, that's where the eye gravitates, because you want to say, well, what's the bad news? So some patients do get problems with memory and with confusion and hallucinations over time. And this is a progressive condition, so it generally does get worse over time, but the pace of that can be fast or slow. So when you have this diagnosis, it changes your whole perspective on life. I've had a lot of patients tell me this. So for instance, you can have a very long horizon of your plans for the future, and all of a sudden you're given this news, and it can really change how you see the future, and it can look like a mountain ahead of you, and it can be hard to see the way forward. But I'll take you up a couple of these little paths of what we do in terms of medical treatment, and we'll touch on the different medications and things so you can understand some of the different routes towards, quote-unquote, your new peak. So in general, you can think of it like a mountain. So the base of the mountain is probably the most important stuff that applies to everyone. And then as you go up the mountain, there's other things that apply to some people but not others. But everyone needs a good support system, and everyone needs the right kind of information. And there's tons and tons of information out there available at your fingertips on the internet, for instance. And some of it's very good, and some of it is not good. So it can be hard to weed that out. So the information is a good base, and then beyond that, so we've touched on already the importance of exercise, and so there are some lifestyle things that are important for most patients, as long as they can be applied safely. And then beyond that, so some but not all patients need these dopamine-based treatments that replace some of that chemical that's missing that works at movement computer. And then some patients need specific treatments for all those other symptoms other than movement, the non-motor symptoms. And then a proportion of patients also end up getting these advanced treatments like deep brain stimulation or gut infusion of levodopa and things like that. But that's certainly not for everyone, but we'll touch on those as well. So there are, like I said, there's a lot of resources out there. The Parkinson Society of BC and the Parkinson Society of Canada websites are very good and reliable, and they have very well written patient materials. The National Parkinson Foundation in the United States is also a good resource, and they have a good website. They have a forum where the director of that society answers patient questions, and they have a pharmacist answering questions. And so that can be a good resource because those are experts in those different disciplines, and they can sometimes be questions that you also have. So it's worth a look. And the Michael J. Fox Foundation is, of course, a foundation that's very involved in research to find a cure for Parkinson's disease. And their website is very research focused, but it does have a blog that updates you as to what the newest things are on the block. And everyone always comes with questions about those things, so it's a good resource for that as well. There are some good books out there as well. I like the one that's listed on the right there. It's quite comprehensive, and it's in I think it's 3rd edition now, and it was written a long time ago with a very excellent voice. So the original edition was extremely well written, and it's been improved on over the years with new information. So if you want more than just a sort of pamphlet kind of level of detail, that's a good one. So in terms of the support system, yes, these are some of the questions that patients ask about their life. So if we take a step back from the medical questions of what the medicines they should be on are, these are the things that are on people's minds a lot of the time. And it's good to think about these things and to talk to your support people about them. So, when's the right time to tell people that you have Parkinson's, or do you even need to? Or, if you're working, when's the right time to bring that up with your coworkers, for instance? When should you stop working? When should you stop driving? These are complicated questions. I don't have a single answer to any of them because it's very different from person to person. And when you meet a neurologist or a doctor, often they're meeting you for the first time when they make the diagnosis or when they're adjusting medications and treatment. So it's sometimes hard to know the person. You can know the aspects of their medical illness, but the people who know you better will provide a lot of reflection and thought about these questions that your doctor sometimes can't provide, at least at the first visit, because they don't really know you as a person until they see you over and over again. There is usually more than one healthcare provider who's involved. Usually the family physician is heavily involved in care. There's usually, but not always, a neurologist involved. And then there's a team of people, usually, that are valuable resources in terms of your healthcare planning. So that will often include a nurse, a physical therapist, an occupational therapist, a speech pathologist, a social worker. And these people bring different things to the table in varying proportions for different patients. Again, we've sort of touched on this. There's going to be more dedicated discussion about exercise later, but just to tell you kind of the basics. So we know that there's a symptom benefit for exercise. So if you do a single bout of exercise, and usually we talk about something that gets your heart rate up or gets the sweat going, we know that there's a symptom benefit. So it's been measured and shown that people's symptoms improve for a few hours after a single bout of exercise. So it's like taking medication. And then we also think, and there's more and more evidence accumulating to suggest, that it probably slows the progression of Parkinson's disease as well. There's probably a few reasons for that, some of which may involve growth factors in the brain, for instance, but it's sort of still a bit smoke and mirrors, and there's a lot of work going into understanding that and trying to harness that and optimize that. So right now there's no kind of prescription for exercise or what kind of exercise you should do. In general, we say, as long as what you're doing is safe, you should do what you enjoy, because that's something that you can integrate into your life and do regularly and frequently. So if you find an exercise that is enjoyable, it gets you breaking a sweat or gets the heart rate up, it's probably good for your Parkinson's, as long as it's not putting you at risk of injuring yourself, like falling. So lots of people do stationary biking, lots of people do vigorous walking or hiking. Some people say gardening. I guess out in Langley, gardening can be an exercise that gets the heart rate up. There's probably a lot to do. But there's many different things. So we think all of them are probably good. Tai Chi has been shown to be good. Yoga has been shown to be good. Tango dance has been shown to be good. So there's lots of things that you can do, and they're probably all good for your Parkinson's. So stay active is the message. This really actually does have an impact on treatment as well. And, about 10 or 15 years ago, there was a lot of worry about the accumulation of medication use over time and the cumulative effect. And people had thought that, we should save levodopa for when you, quote unquote, really need it. Back then, that was the prevailing view. But that view has really changed. So the idea that levodopa runs out or stops working has been disproven. And I could talk about that for a long time, so I won't. But we now have, in general, the idea that we should support people so that they can stay active as much as possible with medication. So our job is to treat you such that you can stay active and exercise. I mentioned some of the other lifestyle things in brief, but we know that coffee has a symptom benefit as well. That was an unexpected finding from a study on caffeine for fatigue in Parkinson's. So it did not improve fatigue as measured in the study, but it was found to improve the motor symptoms of Parkinson's in that study. So there's now a larger study being led out of Montreal, and Vancouver is one of the sites recruiting for that, of the effect of caffeine on disease progression and symptoms in Parkinson's. There's some other things that are probably worth discussing with your doctor. So there may be a higher prevalence of B12 deficiency in Parkinson's disease, although it's controversial. We think that vitamin D is probably important, and it's usually deficient in Canadians because we don't get as much sun. And then, as I mentioned before, so there's an interest, theoretically, in these other foods that can contain nicotine. So something like a Mediterranean diet is probably a good idea. And there are a lot of websites out there that will discuss different dietary measures for Parkinson's. And it's complicated, but in general, heart-healthy eating is probably a good thing. So, again, I'm showing you a very complicated cartoon of the dopamine synapse and what's going on in that brain computer to show you how complicated it is from a kind of molecular and anatomical perspective. So this has led to a very complicated set of medications that can be used in Parkinson's to treat the movement symptoms. And I want to give you kind of an overview of these different options that are out there because many of them will work. And as I said, everyone's different. So you can think of the treatments in kind of groups or classes. So the red circle shows something called dopamine precursors. So we just had the 50-year anniversary of levodopa as a medication for Parkinson's, and it's still probably the best treatment for motor symptoms. So it's more potent than the other medications, and it's more robust, so much so that we often use it as a test. So if symptoms don't improve with levodopa, it makes us a little concerned, because usually they do. That's not always true. For instance, tremor doesn't always get better with levodopa. But stiffness and slowness do fairly reliably improve with that medicine. So most patients at some point will try that medication, levodopa. Probably the second most common that you'll recognize is in the yellow circle, so dopamine agonists. So those include pramipexole, ropinirole, rotigotine, which is now available also as a patch, and bromocriptine. So these medicines just attack the problem in a slightly different way. So levodopa is a precursor to dopamine. So it gets taken up in the surviving dopamine neurons and turned into dopamine, basically in the brain. It always comes with that other element, which is called carbidopa, because if we just gave people levodopa, it would turn into dopamine in the gut, and it causes a lot of nausea and lightheadedness. So it was discovered that if we give carbidopa, carbidopa can't actually get into the brain, but it prevents levodopa from turning into dopamine. So it does that in the gut and in the blood, but once the chemical gets into the brain, only the levodopa gets there, and then it can turn into dopamine and do its thing. So carbidopa is there to prevent nausea and lightheadedness and help the medicine work better. So interestingly, there are some other medications that also sort of boost the effect of levodopa. Those include the blue circle medications, so the MAO inhibitors, so selegiline and rasagiline, and the COMT inhibitors. So the most common one now being entacapone, but there may be others forthcoming, and there are some other ones in the past as well. So those medicines inhibit or stop the breakdown of dopamine in the brain. So once the levodopa gets into the brain and turns into dopamine, that allows it to stick around longer and do its thing. So those medications provide a symptom benefit on their own, but they also boost the effect of the levodopa that's added on. So to kind of summarize that, it's a bit complicated. There's also these other ones in the gray circles, which I won't touch on right away, but so the red circle one, the levodopa, turns into dopamine in those surviving neurons, probably also in some related neurons that are living in the same area of the brain. And the dopamine agonists instead, they actually don't get released by these dopamine neurons. They go and directly attach to the dopamine terminals. And so they mimic the function of dopamine without actually being released by those neurons. So they get around the brain in different ways, and they have different side effects as well. So I can answer questions about that later, but it's a very complex thing, the motor treatment. So as I mentioned, so if you have some impairment in any of these spheres, that's when we usually suggest treatment. So if it's impairing your ability to function at home, at work, to do your recreation or exercise or social things. So some people will say, for instance, that they just are a bit self-conscious or bothered in social situations, so they stop going out. They stop going out for dinner, they stop doing their hobbies, they stop interacting with friends. That's actually a big negative. So if we can target that as a problem with these treatments and get them back out and active, then that's actually a bigger benefit than you might realize. But our goals are to minimize that impact on any of those 4 areas of your life, to maintain your quality of life for as long as possible, and to keep patients what we would call on. So people usually have this daily cycle where sometimes their symptoms are well controlled and sometimes they're not. So when the symptoms are well controlled, we say they're on, or the medication's working. When they're not well controlled, we generally would say they're off, so the medication's not working. Some patients, so probably 50% at 5 years of disease duration, will develop some dyskinesias. These are little wriggly movements or extra movements. And again, if I start talking about that, it could take an hour, so I won't get into it in too much detail, but there's also a state where people are on with dyskinesias. Dyskinesias aren't harmful unless they're severe. If they are severe, they can cause weight loss, they can cause breathing problems, they can cause people to run into things or bump into things, they can cause impulsive walking and fall risk. So dyskinesias can be a bad thing. In a new diagnosis seminar, you generally don't need to worry too much about it right now, but that's something we can discuss in the question period too. So when we see a patient, we make a diagnosis of Parkinson's, we think it's impacting their life in some way, that they should have a treatment for it. There are different ways to start, and there's different approaches. Different physicians will do things a bit differently. But in general, so the sort of textbook approved therapies for first treatment of motor symptoms in Parkinson's are one of these 3 things. So the dopamine precursors like levodopa, the dopamine agonists like pramipexole, ropinirole, rotigotine, or bromocriptine, and the MAO-B inhibitors. Really, rasagiline is the one that's approved as initial treatment. And there are different kind of benefits and drawbacks to these. So, for instance, the dopamine precursors like levodopa, probably the most effective. It does continue to work long term. So I have many patients who've had Parkinson's 20 years or more, and they still get benefit from levodopa. But they are more likely to cause those dyskinesias. over time, as disease progresses, dyskinesias become more of a problem. And sometimes they don't get well absorbed by the gut. So if people have problems with the stomach emptying or other issues, then that can be a problem. The dopamine agonists, they don't cause as much dyskinesia, and they last a little bit longer. And they may actually also help mood if people have low mood. But the downside is probably in 15% of people, they can develop what we call impulse control problems. So there can be problems with compulsive buying, spending money you don't need, hypersexual behavior, eating behavior. And it all sounds very nice, but it can actually be a serious problem. Gambling can be a problem as well. So that's a very serious thing that needs to be reviewed and addressed when people are on those medications, because it can be related. And they can also cause sleepiness. And the other downside is there was a lot of enthusiasm when these drugs first came out that they would, in the long term, be better for patients than taking levodopa, that it might be better for patients to take one over the other for 10 or 15 years. But the long-term studies have shown that that's probably not the case. So there probably is not actually a long-term benefit of taking these instead of levodopa for the motor symptoms, other than those other kind of nuances, so that help with mood and apathy and things like that. The MAOB inhibitors, so they may have some protective benefit. It's very controversial because of how the trials ended up. The biggest downside is that they're very expensive. And the benefit that you get as a symptom treatment for motor symptoms is small compared to levodopa. So it's a once-a-day medication, which a lot of people like. It probably does help the motor symptoms, and it may possibly have some protective benefit, but it's quite expensive. So in general, a lot of patients will do very well starting with levodopa. I touched on this as well, but so the course over time is that things change. So in general, once you get the symptoms well controlled, things change, and they're not well controlled anymore. And that's just how Parkinson's is. It's something that needs to be reviewed and adjusted all the time, because as it changes over time, new problems emerge. And so usually at my visit, I try and ask patients what the biggest problem is. And it can really change over time. So initially, it's often something like tremor or stiffness or walking. But over time, people may say, actually, that's fine, but now I'm really having issues with my sleep, or I'm really having issues with my mood, or I'm having anxiety when the medication wears off, or that kind of thing. So the biggest problem changes over time, and the effect of the medicine, including like levodopa and dopamine agonists, also changes over time. So the duration of effect of the medication gets slower and shorter as disease progresses, because you're losing more of those little cables that are releasing the dopamine as the disease carries on. And so medication adjustments need to happen over time. So when people get these fluctuations, for instance, we will often either adjust the dose of the medication, we might add a different medication to boost the duration of effect or the amount of benefit, or we may add or we may consider something like deep brain stimulation or duodopa, those sorts of things. The Wiggles, this is a kids' music group from Australia, but that's a tongue-in-cheek way to discuss these dyskinesias. So dyskinesias are probably from unregulated release of dopamine in the movement computer there, in the dopamine synapse. So the normal healthy brain will regulate the amount of dopamine that's in that area of the brain. So in Parkinson's disease, as it progresses, the regulation isn't normal. And so people will sometimes dump out too much dopamine from those little cables, and that's when you start getting dyskinesias. It's more complicated than that, but this tends to happen in more advanced disease, although some people will have subtle dyskinesias even early on. So there are many things we often will do for that. So we'll adjust the dose, we can add other medications, we'll reduce the amount of levodopa, or again, sometimes advanced treatments like deep brain stimulation are quite helpful for that. So that's the motor symptoms. I think I took a long time on that, and there's a lot more to talk about still in about 15 minutes, but we'll get through it. So I want to touch on mood symptoms. So this is something I always ask patients about. It is part of the disease to have depression and anxiety. And it's something that I try to aggressively address because it, in the same kind of way, it prevents people from doing things that they would normally do. It prevents people from being social, getting out, exercising. So depression is really important to address. And the medication treatments are numerous, and a lot of them work well in Parkinson's. Exercise also has benefits for depression. But if you're so depressed that you don't want to get out and exercise, then that's another problem. So a multi-pronged approach is usually the right way to address that. But the wrong thing to do is to ignore it. And that often happens too. Cognitive changes. So cognitive means memory and thinking processes. And this can be a feature of Parkinson's disease as well. If we wait 20 years after people are diagnosed with Parkinson's, most people will have some changes in their cognition. That might be small, or it might be significant. For instance, it can, in some cases, lead to hallucinations, and it can lead to behavior changes. So when this starts becoming an issue for people, we first will usually look at the medications and say, which of these can be contributing to the memory trouble? So it's better to take away before we add something else in general. Because a lot of medications, although they might help motor symptoms, can also make it tough to deal with the memory trouble. So we optimize the medications for motor symptoms to reduce the memory troubles, and then some people will take particular medications that help with memory. So donepezil is called Aricept, and this is one you've probably heard of. It's often used in Alzheimer's disease, and it works on a brain chemical called acetylcholine. And we know that actually has a strong effect on memory troubles in Parkinson's. So it's been proven that kind of medication can help. Rivastigmine has the best evidence, but they all work in a similar way. If people do have hallucinations or delusions, they usually require specialist care at that point because there's a lot of risk to just treating with standard treatments for that because they can significantly worsen the movement symptoms of Parkinson's. So we need to be sure that people avoid those drugs that can be bad for Parkinson's when they have hallucinations. This is particularly important in hospital because those medications can be part of standard kind of treatment protocols after people have surgery, for instance, and they get confused and they have hallucinations. That's a risky time to be in hospital with Parkinson's because you can be inadvertently exposed to one of these medications. So it's very important to inform your doctors in hospital that you have Parkinson's and that you need to avoid those medications that can make that worse. There are some medications that can be effective without affecting memory and without affecting the motor symptoms in Parkinson's. And so those are particular ones that we prefer. Usually Seroquel or quetiapine is safe at low doses. There's another medication called clozapine that's quite effective. Doesn't make the motor symptoms worse, but it's very tricky to use from a doctor perspective. There's another medication which has just been shown to be very good for hallucinations in Parkinson's without any effect on motor symptoms because it doesn't work on dopamine. It works on serotonin. That's called pimavanserin. So we're sort of waiting for that one. There was good evidence from a trial about a year ago, and it's very promising for hallucinations in Parkinson's. Sleep problems. Almost everyone has some issue with sleep, whether it's from the motor symptoms bothering them at night, whether they have dream enactment behavior, so punching or kicking or talking in their sleep, or they just have a shallow, kind of fragmented sleep. Those things are all things that we should target. So the graph on there is a graph of melatonin levels in healthy patients and patients with Parkinson's over a 24-hour period. So the healthy patients are the red dots, and you can see that at nighttime, there's a big spike in melatonin. In Parkinson's, there's a very shallow spike. So we think this is actually a feature of Parkinson's disease, and many patients will have better sleep when they're on melatonin. So we often talk about that as an easy thing to do to help with sleep. The side effects of melatonin are few, but they include drowsiness in the morning if you take too much, and they can also sometimes cause vivid dreams. So if you can get by and tolerate the vivid dreams, if you have them, then it can often help improve sleep quality, which can help with the symptoms. And melatonin is also one of our first line treatments for this dream enactment behavior, punching and kicking in sleep, which is usually a complaint of the bed partner. Plumbing problems. So this is also very common. So the bladder and the bowel don't work normally in Parkinson's. So the most common bladder complaint that I hear, and I hear from almost every patient to some degree, is that they have a sudden need to go sometimes and they can't get there quickly enough. So bladder urgency. So there are different medications that can be used for that. Ditropan, Detrol, can sometimes have some cognitive side effects or memory side effects. So we tend to look for these other ones, Vesicare or Enablex, or there's a new one called Mirabetriq or Mirabegron that's also quite effective. And then constipation, almost universal at some point along the course of Parkinson's. The 3 Fs are usually the best place to start. So fruit, fiber, fluid, and then so stool softeners, there's a whole variety of them out there. It's probably best to avoid the ones that are sort of stimulants of the bowel because they're not great for long-term use and you can become dependent on them. But there are many, many options. But fluid and fiber are a good place to start. Swallowing and chewing issues. So a lot of patients complain of drooling. And this is not actually from overproduction of saliva, but from lack of those automatic swallowing movements that we all take for granted. So normally if you produce saliva and it's pooling in your mouth, you'll automatically swallow it. That movement can be gone in Parkinson's, and so people will sometimes get saliva trickling out of the corner of the mouth. One of the easiest things to do is to keep a piece of gum or hard candy in the mouth, as long as you're not going to choke on it, to stimulate those swallowing movements. But sometimes we treat that with Botox even, or with drops that can dry up the fluid. And then swallowing issues are a big deal as well. There's a lot of tips and tricks that the speech pathologist will give for swallowing, like tucking the chin, eating more slowly. Sometimes patients need texture changes in their diet. So there's a whole variety of things to approach from a non-motor perspective. We also heard about speech and voice and the Big and Loud program. But people usually will say, well, that's fine, but what can I do to cure it or to get rid of it? I want to stop Parkinson's. And the long and short of it is, right now, we don't have anything that's been proven to do that. There's a lot of enthusiasm for exercise, but we don't have a pill that we can give you that will reverse Parkinson's or that will stop it. There's still a lot of things in the pipeline that are promising, but this is kind of the state of the field. So we think exercise might help. None of the treatments that have been highly kind of expected to show protective benefit have panned out. The major unmet needs. So like I said, so one of the main things is trying to get to the rusty barrel before it springs a leak. So trying to find a way to diagnose patients earlier, before they present to the clinic with stiffness and slowness, because we think the horse is already out of the barn at that point and we're chasing after it. The other major unmet need is to have a medicine that's been proven to slow down Parkinson's. So there's lots and lots of effort being invested in that. And then the third thing is, even if we can stop Parkinson's, if you've already got these symptoms when we stop it, we're probably still going to have to manage the symptoms, even if they're not getting worse anymore. And so that's probably always going to be an issue, and we need better treatments for those symptoms that don't have the same side effects that we are challenged by today. So that's where research is kind of focused right now, in those 3 areas. And there's many, many different things to talk about in terms of up-and-coming players in terms of treatment. We'll leave that, I think, mainly for the question period, but tons and tons of things in the pipeline. A lot of the sort of movers and shakers, if you'll excuse the pun, in the field are of the opinion that Parkinson's is maybe going to move towards like a cocktail approach to slowing or stopping disease progression, much like is used in cancer. So it may be that attacking all of these different pathways and processes in the brain cell that we've learned about from genetics and things like that, we might have to attack a bunch of different things in order to actually have a cumulative effect on slowing the disease. And so the cocktail approach, alcohol-free cocktail, might be the wave of the future. In terms of better symptom treatments, so there's something called Ritigotine, which is a long-acting form of levodopa. There's this accordion pill. Those are new things that are coming out that are sort of longer-acting levodopa that are better absorbed. There's this thing called a microneedle patch, which is being developed in Israel, where they have a patch that has very, very tiny needles, and then that's attached to tubing with a fluid of levodopa, and then it delivers it through all those tiny needles. Apparently it doesn't hurt. Then there's also something called inhaled levodopa, which is in testing now for sudden, unpredictable off periods, when people have wearing off all of a sudden and they have really unreliable absorption of medication. And then there's also a sublingular, under-the-tongue version of dopamine agonist called apomorphine that's in testing. And then I think every patient has asked me about this cancer drug since this press release came out a few weeks ago. So this will often happen, that there's a promising new therapy that comes up. So I'm skeptical about these until they're well proven in a big placebo-controlled trial, because we know that there's a very strong placebo effect in Parkinson's. We know that it's been proven that saline that's been said to be more expensive gives more symptom benefit than saline that is said to be inexpensive or cheap, if they're both thought to be active in Parkinson's. That's because the placebo effect is mediated by dopamine. So when people believe that they're getting an effective treatment, that actual belief can release dopamine in the brain and help symptoms. So this medication is about $10,000 a month, and it was given to about, I think, 12 patients, and they all felt much better. So we don't know yet, until that's compared against a sugar pill, if that's a very strong placebo effect or if it's actually a disease-specific effect. So I'm very enthusiastic when something like this comes out, but I'm also skeptical, and I'll await a good quality study to prove that it works. There is a theoretical reason why that medicine might work in Parkinson's, which is that it seems to have an unexpected effect of stimulating that waste disposal system in the cell. So I'm enthusiastic, but we'll see. There are lots of research things that are going on. The ones with the red arrows are being done at UBC in Vancouver, so there's a very strong genetics program and a very strong imaging program in Vancouver, and they are always very happy to talk to patients who are interested in participating in those studies. This is the Center for Brain Health there, so it's this building. People think those are octopi, but they're supposed to be neurons. So that's where a lot of that research takes place in Vancouver. But really, just remember, like this picture, you need a team of people. Our guidelines for Parkinson's in Canada say that you should have access to physiotherapy, occupational therapy, and speech pathology at a minimum, and usually the team is a lot bigger. But those things are all very important to look into as well. But at the end of the day, when you get near the top of the mountain and you feel like things are going well, things will change. But it's really important to not get discouraged because this is a very challenging illness, not just in terms of the medical treatment, but in terms of the patient perspective. So I hear every day from people saying how it affects them, and I know it's really tough. But just as an overview of all the stuff, I hope that gives you some ideas of how things might look going forward. So I'll take your questions now, and thank you for your attention.
Caroline has the mic, and just put up your hand and she'll come over and give it to you.
I've just heard recently of it's called PONS device that has been used for MS, that there's possibility that this could help with Parkinson's.
Yeah, so comment on that. So that's the tongue stimulator. There's no great evidence in Parkinson's for that yet. I'm always open to things like this. So I'm a little bit skeptical and wary of it because I don't understand how theoretically it could help in Parkinson's. And it's a device. So devices are sort of sexy to people in a way when they come out, and I would like to see it proven to be effective. But if patients do get a benefit from it, I'm open to it. I don't know of any good quality studies with it in Parkinson's. Mm-hmm.
There's been a lot of controversy about caffeine and whether to have coffee or not to have coffee, or whether to have decaffeinated tea or coffee. You seem to recommend that it's okay. Why would it not be okay?
That's a great question, and it goes back to everyone being different. So for instance, some people who have heart conditions, caffeine will cause palpitations and things. People who have a lot of anxiety, caffeine can make that a lot worse. People who have tremor, sometimes caffeine can make the tremor worse as well. So really the idea is when you try anything new in Parkinson's, you should take a step back, only change one thing at a time, and take a big view of, are you better or worse after a month or so? So without caffeine for a month, and with, do you feel better? That's the way I would approach it for the individual patient, because some people may say, well, maybe it's helping a little bit, but maybe they're ignoring that they're having anxiety, or they're having more tremor, because theoretically it should help. It doesn't mean that it's for everybody. So I would if you're interested in adding that to your kind of daily regime, I would try to only add that thing and change nothing else for at least a few weeks or a month, and then take a step back and say, did this help me or did this make things worse? And if it doesn't help or it makes things worse, it's probably not worth continuing.
Let's start with decaf or not?
Decaf, yeah. So in the study where it was shown to have a symptom benefit, it was with caffeine pills, so not the actual brewed coffee. Now, theoretically, there might be some antioxidant type things in coffee that are good, but we just don't know. So that's where decaf would have value, is because it would also have those antioxidant things, but it's the actual caffeine that we think helps the motor symptoms of Parkinson's, and that's the thing that causes tremor. Of course, decaf coffee also has a little bit of caffeine in it, but it's a small amount, so don't go for the venti at Starbucks right away, because that stuff is very potent. Mm-hmm.
Poor thing. Hi, we just had a question. PJ was given mirtazapine, razagiline, and levodopa, and told that there might be a contraindication between those drugs, but that it would be okay. So we went ahead and then got a call from the pharmacist who totally freaked us out, but then we had to lean back on the fact that obviously the neurologist is aware of these things. So what is, we didn't ask what the contraindication was, and I'm assuming, we took the medication, and then I just stared at my husband for an hour to make sure nothing bad was going to happen. But what is that?
Yeah, so first of all, I'm really glad you asked that question, because this is a very, very common issue when we prescribe rasagiline, or Azilect as it's called, or selegiline, which is the related medication. So these inhibit that brain chemical called MAO-B, monoamine oxidase type B. So dopamine is one of these monoamine neurotransmitters, and there's another one called serotonin. And so monoamine inhibitors can theoretically raise serotonin levels. So rasagiline doesn't really do that very much, but the theoretical risk is something called serotonin syndrome, when you take more than one antidepressant type medication that works on serotonin. And so rasagiline is flagged by pharmacy databases as an interaction with any antidepressant drug. So because we know most patients with Parkinson's have depression, and most of them do need a treatment, this is very, very common when we prescribe rasagiline. So it has, to my knowledge, never been reported in the tens of thousands of patients who've taken the combination of rasagiline and an antidepressant drug like mirtazapine. But because it's flagged by the pharmacy database, people will say you can get the serotonin syndrome from that, and it scares a lot of patients off. But I would, I guess, proceed with caution, as with starting any new medication. But I think the real-world risk of serotonin syndrome with rasagiline is very low, almost none. And mirtazapine, by the way, is a great choice for antidepressants in Parkinson's, because it helps with sleep maintenance as well. And it also, in patients who have tremor, can help with tremor. That's been shown in small, unblinded studies, but anecdotally, a lot of patients, especially if they have tremor that doesn't get better with levodopa, they'll find that it's a bit better with mirtazapine or Remeron. So, yeah, that's a good one.
Is there a difference, or what is the difference between Navadopa and Cinemet?
Right. So Cinemet is a brand, so it's the most common brand name, and Cinemet means without emesis, without nausea. So that name comes from the fact it has that carbidopa in it, because the carbidopa is supposed to prevent the nausea. But there's other brands. So the generic version would be called Levocarb or something like that, Levodopa, carbidopa, and it doesn't really matter which one you're on in the long run. Some people find with the brand name Cinemet, they feel like it gets absorbed a bit better. Other people say with the generic from this particular company, they feel like it gets absorbed a bit better. So it's different from person to person. In general, though, if you switch from one brand to the other, these generic ones have to be proven to have within 20% the same absorption in kind of laboratory testing. So that might mean if you switch brands, you might get 80% of the effect you were getting before, or you might get 120% of the effect you were getting before. So switching brands can have some effect on how your symptoms are treated by it. So the other thing to say about that is, so controlled release or long-acting levodopa, the brand probably is a little more important, because those are specially sort of formulated to be sort of controlled release or time release. And a lot of people say that they prefer the brand name in that case for the controlled release, because it seems to just work better. And the absorption of the controlled release is usually only about 66 to 75% as good as the immediate release or the yellow pills. It's different from person to person in summary, but in general, if you start with one, I would stick with it because it's easier to adjust that way. Yeah.
When is the best time to take the pill? Mm-hmm. I take 4 a day right now. I've been told to take it with a meal.
Excellent question. That's a very good question, and it's also a very common area of confusion. So one thing which will impact the absorption of levodopa for sure is food. So particularly protein-rich meals, things that have protein. So that can be dairy products, it can be nuts, it can be fish, it can be meat. Anything that has protein in it is going to prevent the levodopa from being completely absorbed. Might be a little bit of an effect, might be a lot. But for instance, I've seen patients who've been taking levodopa for many years, and they take it with yogurt. They eat it with yogurt or something, and then you're not getting as much bang for your buck. The other side of that is, if you do take it with food, it can help with nausea. So initially, when people first start using levodopa is when they tend to have most of the nausea. And so particularly when you're first starting the medication, it does help to take it with some food. We usually suggest that people take it with something like crackers or cookies or toast, something that doesn't have a lot of protein. Does that answer the question? Oh, partly. But your question really was, when should I take it? Like, when in the day should I take it? And that's different from person to person. So what matters is that it's not wearing off and that you don't have good symptom benefit for many hours in the day. So sometimes early on, people will get 5 hours of good effect from one dose, from one yellow pill. Some patients will say, well, I get a good effect for 3.5 hours, and then it seems to wear off. So for a lot of patients, 4 or 5 hours is a pretty good interval, but sometimes after 5 or 10 years, people will be taking the medicine 3 hours apart or 3.5 hours apart. Usually it's not closer than 3 hours. And usually early on, people will take it 4 times a day, sometimes 3 times a day. People will even get by with that. But it's different. So 4 hours is a very reasonable, 4 times a day, so 7, 11, 3, and 7, or 7, 12, 5, and 10 is a kind of a common sort of schedule. And usually I would take it when you get up. The point of the medication is to help you move better, and so it's best to take it first thing in the morning. So a lot of people will have it on the nightstand, and they'll take it first thing when they get up, and then it sort of kicks in by the time they're down for breakfast. And then if you've taken it at least a half an hour, some people say an hour before a meal, then you should be able to completely avoid that protein effect, and then have your eggs and bacon. If you do have a big meal, then you're going to take your medication afterward. It's best to wait at least an hour. And for some people who have slower digestion, or they might have slower release of food from the stomach, it might even take longer for them to digest a meal. So in general, I have found that patients seem to get better effect if they take the medicine before they eat by at least a half an hour. Yeah.
My neurologist says coenzyme Q10 is a waste of time. But I had a friend who went to Mayo Clinic and they put him on it.
So should you get another opinion? Is the kind of question, should you go to the Mayo Clinic or something like that? Yeah, so it's always reasonable to ask other opinions, and you know, people will also have different perspectives, even if they agree on the diagnosis, and they might give you ideas about things that you haven't heard before. So I think that's reasonable, and a lot of people, you know, to be honest, it can be quite a shocking diagnosis to receive, and it's something that you want to be sure of, I guess, if you're, you know, looking at that timeline in front of you and saying, well, how have things changed? What am I going to do for the next X number of years while I'm struggling with this? So I can totally appreciate that people want another opinion a lot of the time, and I think that's appropriate. And among neurologists that I've met, I don't think people are offended by that. It's best to be open with them, so you can say, you know, I'm going to see this other doctor, because then you can plan, you know, who's going to be the quarterback, who's going to be helping you make the most treatment decisions. But yeah, I certainly don't. I'm not going to tell you you shouldn't go to the Mayo Clinic if that's something you want to do, or you know, a lot of people do that. It can be expensive though, and the downside is if you invest all of that time and effort and money, and then you come back in the same position you were in before, some people are frustrated by that. But sometimes it's quite helpful as well. So yeah, I can't give you a firm answer.
Okay, we have time for about 2 more questions here.
We are wondering about the Ritigotine patch, the side effects. There seem to be a lot of side effects.
Yeah, so Ritigotine is one of those dopamine agonists, and so they don't have as much data on the impulse control problems as the oral or pill form dopamine agonists. Theoretically, they should also have risk of the impulse control problems and sleepiness that the other dopamine agonists do. But also theoretically, if you're taking a pill and then you get a little spike in the level and then you get another spike when you take it again later versus a patch that delivers it kind of steadily at the same level throughout the day, the patch should theoretically be better for those side effects. The other issues have to do with the patch itself. So a lot of patients will find that their skin is irritated by these patches, and it can cause blistering and itchiness and things like that. So some people just can't use it because they can't tolerate the patch as a delivery system. But in general, so the side effects are similar to the other ones. So it's problems with sleepiness, problems with impulse control are the main ones we think about. Yeah, so the place where I've found the Ritigotine patch is very helpful is if people have significant mobility problems overnight and they have a hard time, because a lot of times people will wake up and they need to go to the bathroom at night. That's almost a universal thing in Parkinson's, and then they have a hard time getting out of bed, and they have a hard time moving because their medication wore off, you know, 3 hours ago or something when they were asleep. And so for those patients, sometimes they'll take another yellow tablet or immediate release levodopa in the middle of the night. Some people will take a long-acting or a controlled release levodopa at bedtime, and sometimes that gets them through. But some people struggle despite those basic steps, and sometimes those patients do really well with Ritigotine patch because it delivers it continuously overnight. And then on top of that, during the day, they may still get some benefit from it, but they might add then the other medication when they're active. There is sort of like a gas in the tank kind of effect. So when you're sleeping at night, you don't necessarily need as much gas in the tank. But when you're up and about and you're going out for a walk or something, you might find that you need your medication more. So having a little bit overnight with the patch is sometimes enough to help people sleep better and to help with the mobility overnight.
I'm currently on my medication, 2 different meds for the last 6 months, and everything's been going fine. But lately, what's waking me up at night more than having to go to the washroom is a constant sour stomach. And I suffer with it all day, and then at night it wakes me up, so I'm not getting a decent sleep.
Yeah, so hard to know for an individual without having gone through everything with you, but the common things that can cause that are reflux, and also some people have a bug called H. pylori that can cause ulcers. But your family physician should be able to lick that problem. Usually that goes right away with a medicine for acid, for stomach acid, that kind of thing.